So this time we're still in Unit 2. We're going to talk about degenerative diseases. Primarily our focus is Alzheimer's and Parkinson's disease. So if you're not remembering those two disease processes, you need to go back and look at the pathology. One of the main things to remember when we're talking about pharmacologic management of Parkinson's and Alzheimer's is that any medications that we give are not going to cure the disease. These are progressively degenerative diseases. The neurons are damaged, so they're not producing the neurotransmitters, or they're not responsive to the neurotransmitters. So we're not going to see reversal. We can delay symptoms, we can manage symptoms, but we're not going to cure the disease. For Parkinson's disease, when we give the meds, we want to see an increase in ability for them to perform their normal daily activities. So we want to see improvement in their motor abilities, their ability to ambulate, dress themselves, feed themselves, because once you review this disease process, and understand those symptoms, those are the things that we're going to reduce temporarily in order to promote quality of life. When we give medications for Parkinson's, we're trying to, for a period of time, restore dopamine function and block acetylcholine function. Remember that dopamine is inhibitory to the nervous system, so it kind of relaxes things, especially when we're talking about motor function. Acetylcholine is stimulating, so it stimulates unconscious muscle movement, and that's why we see the symptoms in Parkinson's that we do, because when we lose dopamine, then acetylcholine's function becomes more apparent. So we see those tremors, we see the change in balance, we see the change in posture, because of the not overproduction of acetylcholine, but the overfunctioning simply because the dopamine isn't there to counteract it. So with Parkinson's, they lose that dopamine-producing neurons, and that is what is affecting their activities of daily living. And so that is our goal, is to regain that. So as you can imagine, pharmacologically, we're going to give medications that have a dopaminergic action. We want to increase the levels of dopamine available because it's not being produced as it should be. Or we might want to use medications that reduce the action of acetylcholine. Either way, we're going to have some symptom relief. So one of the most common agent that we use is levodopa. And levodopa is a precursor to dopamine synthesis. We use levodopa, this precursor, as opposed to giving dopamine, because dopamine doesn't cross the blood-brain barrier, whereas levodopa will cross, and then it can be broken down and utilized as dopamine. When we give levodopa alone, a huge portion of it is broken down, and so we have to give relatively large doses of dopamine, or of levodopa, to get small amounts of dopamine. And it can take up to 6 months for therapeutic effects to be seen. So patients will often, patients and families, I guess, lose heart. They feel like it's not working because it takes so long. And so this is a point of patient teaching and patient support to make sure they understand that this is not going to be a quick reversal, even though we've started on medication. The other thing about levodopa is that it has a tendency to lose its effectiveness over time. Or we have what is called an on-off syndrome, where it seems to be working, and then they'll have periods of time where it doesn't seem to be working, and then it kind of kicks in again. For this reason, we often have patients do what's called a drug holiday, where they might spend several months off of the medication and then resume it, and then they start to see the benefits from it again. Side effects typically are dose-related and can include loss of appetite, nausea, vomiting, and orthostatic hypotension. So we have several nursing problems associated then with starting the levodopa. They're already going to be having some anorexia just because of the disease process. It may be related to depression that is common with Parkinson's because of their change in their abilities. They don't lose cognitive function. They simply lose the ability to control their body. And, well, simply is not a good word, but you understand what I mean. And so, just think how depressing that is to not be able to do the things you normally would do because your body doesn't respond. And your brain is your mind is working appropriately. That can be very frustrating. Couple that with the tremors that can make getting a spoon or a cup to your mouth without spilling. Nutrition becomes a real issue. Orthostatic hypotension as a side effect for the levodopa, coupled with the imbalance that is experienced from Parkinson's disease, we've got an increased risk of falls. So, you want to think about how does the side effects of this drug compare to the disease process, and what kind of nursing problems is my patient going to have? And this is important to take care of that patient. And for this narrow period of time, it's important for you to be able to answer test questions as well. We want to also consider not just normal side effects, but adverse effects. And remember, side effects are common. Adverse effects are serious. And so we want to look for signs of toxicity, which will include involuntary movements. Now, they already have some because they have Parkinson's. So we have to look at what are involuntary movements. This could be chewing motions, lip smacking, grimacing. These are not the typical Parkinson's disease movements. So we see the pill rolling tremor, the off-balance gait. Those are Parkinson's symptoms. But when we start seeing the lip smacking, the grimacing should be fairly apparent because Parkinson's patients typically have a flat affect. They don't demonstrate a lot of emotion through their face. So we want to be looking for that. Nightmares, confusion, hallucinations, these are additional symptoms of toxicity. Tachycardia and palpitations would also be additional signs of toxicity. We want to consider medication interactions, such as antacids. Antacids taken with levodopa can increase the absorption, which is going to increase the risk of toxicity. Pyridoxine, or vitamin B6, reverses the therapeutic effect of levodopa. Now, normally we don't get enough vitamin B6 through our diet to cause a problem. But if a patient is taking B supplements or multivitamins for any other reason, then that could definitely be enough to cause us a problem. So a consideration when we're doing our assessment of our patient, dietary assessment, medication assessment, are they taking these things? If they're not seeing the results they expect, it's something we want to go back and review. So keeping these things in mind can affect the entire course of treatment for the patient. Antihypertensives increase the risk of hypotension, and anticholinergics. Now, we give anticholinergics to help control some of the symptoms of Parkinson's, but at the same time, because if we give it with the levodopa, which we do, we're going to see increase in those anticholinergic side effects, which at this point you should have a good grasp of anticholinergic side effects. So when we're talking patient teaching, they need to know what the symptoms of toxicity are. We need to include family in that teaching. We need to teach them not to take multivitamins with the B6. And if they experience nausea and vomiting with the levodopa, that they can take it with food or milk, and that will decrease the amount of GI upset. Now this slide I just wanted to show you, just to kind of give you a visual of what happens with dopamine and levodopa. So you can see that at the bottom on the right, it shows dopamine is just blocked by the blood-brain barrier. But levodopa on the left will go in, and it is taken up by the dopaminergic neuron, converted to dopamine, and then put into that synaptic space where it becomes available then to move on down the line to the next neuron. The other drug that you most often will see, truly most often, is carbidopa, levodopa combination. So we give a lot of Sinemet to Parkinson's patients. And the reason for that is because of the carbidopa. Carbidopa is an enzyme inhibitor, so it blocks the breakdown of the levodopa, which is very beneficial, because if we give levodopa on its own, it requires a very high dose. Well, the higher dose that we give, the more side effects we're going to see. So by reducing that dose of levodopa, we reduce the side effects. And by giving the carbidopa, what we give isn't broken down, and now we have more available for the brain to utilize. So that little picture box shows you what happens when we give the levodopa versus the levodopa plus carbidopa. And I think it shows very well what's happening. When we give levodopa alone, 100% of it is utilized by the body, but a lot of it is excreted unchanged. And so a very small amount, 2% of what we've given, is used by the brain. When we give it with carbidopa, you can see we give 1/5 of the dose, but we still get that same amount that enters the brain. So 10% of the dose. And so this is a huge difference. So we can reduce side effects while still getting the therapeutic benefit of the levodopa. All the side effects that we would see with Sinemet, the carbidopa-levodopa mix, are related to the levodopa. We can also give dopamine agonists. Now you know what an agonist is. It's a helper, a facilitator. So these medications are going to stimulate the receptors. It can be used alone, or it can be used with levodopa. Serious side effects are related to the dopamine toxicity. And so we're going to see all of the same side effects that we would see when we administer levodopa. So again, our therapeutic effects, we want to see improved motor function, improved balance, fewer tremors, improvement in ADLs. Hopefully we'll be able to decrease our dose of levodopa if they're used together. Side effects are dose-related and reversible if caught in time. So we need to make sure that we are observing for those side effects. Comtan inhibitors act a little bit differently in that I got interrupted, and so I kind of forgot where I was. So Comtan inhibitors work a little bit differently. Instead of providing dopamine or stimulating the production of dopamine or the uptake of dopamine, Comtan inhibitors reduce the destruction of dopamine. If you remember a couple of slides before, you can see that dopamine is broken down throughout the body. And so we want to, if we stop that breakdown, then we have more dopamine available for to reach the brain. So by giving in Comtan inhibitors, then we can use natural dopamine. The Comtan inhibitors have to be used with carbidopa, levadopa, so we have enough dopamine available. One of the side effects is that it changes the color of the urine, and just a kind of a fun fact, the metabolites for dopamine can react with cleaning agents or iron in water, so that they may notice that the water in the toilet changes color, after, even though the urine itself didn't seem to be miscolored. Anyway, I just think that's kind of interesting. So, sorry about that. Moving on. Side effects of Comtan inhibitors, again, are related to the dopamine. So we're going to see those involuntary movements, the lip smacking, chewing motions that signify toxicity. Changes in level of consciousness, such as sedation, confusion, hallucinations. Changes in orientation, not knowing who they are, where they are. Diarrhea, orthostatic hypotension, those are also going to occur. Therapeutically, what we hope to see is decreases in that on-off syndrome, so we don't have the fluctuations in motor control. They have more on time, and we can use a lower dose of levodopa. We can also decrease the risk of dyskinesias associated with the levodopa, and that's what we call those involuntary muscle movements associated with dopamine are dyskinesias. Interactions, obviously it interacts with levodopa, but that's a beneficial interaction to some extent until we start seeing serious side effects. And again, antihypertensives, because we're going to see a decrease in blood pressure. And I mentioned earlier that we do give anticholinergics to Parkinson's because, again, part of the problem, the reason we see the symptoms isn't because of the lack of dopamine, it's because there's not a balance between dopamine and acetylcholine. So I guess in a sense it is the lack of dopamine. But anyway, so because of that imbalance, acetylcholine kind of asserts itself and becomes more apparent, and we start seeing those motor changes. So if we give an anticholinergic, then that blocks the effects of the acetylcholine. So by giving the anticholinergics, we provide symptom relief. So the pill rolling tremor, the drooling, those things will diminish. The anticholinergics do not help with the rigidity that causes the change in gait. It doesn't change the posturing that we see with Parkinson's. And it doesn't make their reaction time any faster. But some of the things that are embarrassing, like the drooling, can be controlled with the anticholinergics. Adverse effects are going to be the dry mouth, blurred vision, tachycardia, urinary retention, constipation, all of the things that we expect to see with... Huh? Oh, okay. All those things we expect to see with anticholinergics. And so ask yourself, what kind of side effects are these? Besides anticholinergics, they're stimulation of the sympathetic nervous system. Anticholinergics are going to interact with many medications and alcohol. And because of the anticholinergic effects are going to be increased when taken with levodopa, we want to make sure patients understand that there should be a 2-hour window between taking the levodopa and taking the benzotropine or their anticholinergic agent. All right, so Alzheimer's. We're going to move on from something else. So Alzheimer's disease, again, medications are not going to cure the disease. They simply will slow the progression. We want to start giving medications for Alzheimer's as soon as a diagnosis is made to prolong the mild to moderate stages. They're not going to be beneficial at all once the patient gets into the severe stage of Alzheimer's. So typically they should be DC'd, at that point. The medications are only going to work as long as there are functioning neurons. And that's the problem with Alzheimer's, is that we're actually losing neurons. And so eventually, that degeneration is just going to be overwhelming. There's no amount of medication that's going to bring back that function. So with Alzheimer's, we're losing the cholinergic neurons. And so with Parkinson's, we saw an over effect of acetylcholine. With Alzheimer's, we're seeing a decrease effect of acetylcholine. So because we're losing these cholinergic neurons, there's a loss of ability to perform tasks that require acetylcholine as a neurotransmitter. And so the function of the parasympathetic nervous system declines. And this is going to affect memory, emotions, and the ability to learn new tasks. And that's one of the hallmark symptoms of Alzheimer's is the loss of short-term memory and the inability to learn new things. So learning and memory are affected. So we see memory loss and cognitive decline. Again, overall, we hope to give the patient an improvement in functions of activities of daily living, control their behavior, and prolong their cognitive ability as much as possible. Primarily, drugs of choice are going to be acetylcholinesterase inhibitors. And again, we've got ACE on the end, so that means that we're stopping an enzyme that breaks down acetylcholine. We have donepezil and tacrine. Now, you will find these in Chapter 50, not in the Chapter 15 or whatever that talks a lot about Parkinson's. So look for that there. The action of these medications is to inhibit acetylcholinesterase, allowing acetylcholine to be more available at cholinergic receptors. Primarily, again, we're going to use that in the early stages of Alzheimer's. We hope to see improved cognitive skills in the areas of, say, word recall, naming objects, and ability to do a task. Part of the assessment for Alzheimer's is to point at an object and say, can you tell me what that is? And, you point at a clock and they say sock. Well, obviously that's not what it is. And, they may know what its function is, but they can't recall what it's called. So those are the kind of things we want to see. Side effects are because of stimulation of the parasympathetic nervous system. So what does that mean? When we stimulate the rest and digest, that means we're going to see increase in GI function, so diarrhea, nausea and vomiting. We're going to see decrease in heart rate, blood pressure, because we're resting. So those are the side effects that we're going to look at. So cholinergic effects are very common. Some of the things are going to be more serious, such as bradycardia. Tacrine has more of a hepatotoxic effect than donepezil does. Interactions will include anticholinergics for obvious reasons. We don't want to block those acetylcholine receptors, so we certainly don't want to give anticholinergics. And it can also interact with anesthetics. So that's the end of degenerative diseases, and hope it was helpful for you.